Good afternoon, everybody. We're just going to wait a couple of minutes for the rest of the participants to join us, and we'll be back with you shortly. Thank you. Good afternoon, everybody. Welcome to the LIMIX Annual Forum. I'm Cheryl Martin, and I've been the Acting Manager for LIMIX for the last 12 months. Many of you will know Alana Solo, who was the previous manager, and Alana resigned in July. So I'm here today, believe it or not, with a number of my team members here in the boardroom at Bendigo Health. We're all being put through our paces, doing this as an electronic Zoom Teams interactive annual forum, which is a new experience for us. So we're really delighted that you can join us, and we'd like to keep the tone of this as an interactive session with our really important stakeholders and some of our team members, etc. But before I proceed, I would like to acknowledge that today we are meeting on Dja Dja Wurrung country, and I'd like to acknowledge the traditional custodians on this land in which we meet and pay my respects to their elders past and present. And I extend respect to Aboriginal and Torres Strait Islander peoples here today. And I'm also thrilled, and I hope you noticed the beautiful artwork that we shared on our screen while you were waiting. And that's been a piece of work commissioned by the Integrated Cancer Services across Victoria, painted by a local Aboriginal artist. And the title of that is Hope and Connection, Bunjil over Wurundjeri Land. And so you'll get to see that more across the ICS during the forthcoming year. So thank you for prioritising your attendance today. Everybody's busy, people are short-staffed, and we're really delighted that you've joined us for our annual forum. I'd like to tell you a little bit about our team, because it's certainly not just about me sitting here. The LIMIX team is made up of a team of project staff, data team, and we're delighted to say administration support as well in recent times. We are overseen by a governance group, and that governance group is made up of CEOs and people that have senior roles within health services across the Loddon Valley region. And we have memorandums of understanding with our member organisations across the region. And we have relationships with a lot of other key stakeholders in the cancer service sector across this region. And also we intersect with our other 9 integrated cancer services across Victoria. We are funded by the state government, and our mandate is to act as a quality improvement organisation for cancer services so that the care and support and the patient journey is aligned to optimal cancer care. With our team, I also meant to mention that we have a clinical component to the LIMICS team. So we have a clinical directorship team, and that's made up of a medical oncologist who's at Bendigo Health. And this year we're really delighted to say that we've added 2 GPs to our clinical director team. And that's been a fantastic enhancement that has provided greater insight into the primary care interface of the cancer service sector, and provided a lot more capability for us to not just understand that, but to provide useful interventions that utilise that primary care collaboration, as well as the acute sector that patients experience. So our work is aligned to the Victorian Cancer Plan, and we intersect with a number of other agencies who also have the Cancer Plan as the foundation for the work that we do in this sector. But very importantly, our work is based on collaboration, and it's based on collaboration with you as hospitals, health services and stakeholders, and people that have not just an interest, but a real commitment and a passion to stand by people on their cancer journey. And we can talk about that in a sort of a rhetorical sense, but we know that cancer touches people close to all of us. And we know when we've supported people on that journey, just how important their experience is, and how that often, I guess, shines a light on the things that we think are less than ideal, and it creates opportunities for service improvement. And that's the key work that we do. We are really committed to also listening deeply to the voice of consumers. So to those people that have lived experience of a cancer journey, they bring a great degree of insight into our work. And gone are the days that consumers have a tokenistic sort of place at the table. We have consumer reps on our governance group. We encourage our health services to have structures in place that include a genuine consumer voice. We have staff that specifically look at innovative, creative and sustainable ways of empowering consumers to feel part of our team. And at a project level, we try very hard to also engage ways of really legitimising and listening and responding to the voice of the consumer. And today, with some of our presentations, we will hear how that's happened in action. So the thing with quality improvement, which is our mandate, is that it's often incremental. It's, as those of you know out in the field, like we can have so many wonderful ideas, but there's often internal and external barriers as well as enablers to quality improvement. And so sometimes it does take time to get traction for change, work out what are the things that are going to really support not just the change, but to embed that change to make a sustainable and ongoing difference to the work that we're all committed to in the cancer space. And today we're going to hear about some of the recipients of the LMICS grants, because our approach is like I said at the start, it's really about building those relationships, because it's you in the field that have fantastic insight into what will make a difference, what can make a difference, what's realistic, and what are the resources and supports that you need in order to see those changes occur. And with the small grants programs, that's a fantastic opportunity for LMICS to listen to what our stakeholders and our member organisations are saying the needs are out there. And it, excuse me, I'll just have a little drink. They do this online. It's allowed. So in 2021, we had a very transparent process where we advertised for applications for our small grant project. And we shortlisted that and awarded 8 small grants across the region, right? Our region's a large region, from right up to the Mallee, the north of the Mallee and Mildura, and to the southern Mallee, and then down towards the edge of metropolitan Melbourne as well. So we've awarded 8 small grants, as well as 3 quite large model of care projects, which totaled just over $350,000 of investment into this quality improvement activity. So today we're going to look forward to hearing from 4 of those recipients, from Kyabram, from Bendigo, from Echuca, and from Swan Hill. And there's going to be some live presentations, some PowerPoint presentations, and then the opportunity to also have questions and a little bit of discussion from you as participants. So if you would like to use the chat function, I'm just looking to my colleague here to see that I'm giving the correct instructions. Put your questions in the chat function and we will curate those and present those at the appropriate time. Okay, and of course, thanks to my LMICS colleagues here that have made all this happen. There's lots of busyness going on in the background, so I really appreciate that. So I'd like to introduce our first presentation, which is from Callie Scory. Callie's the Acting Cancer Service Manager at Kyabram District Health. And the small grant project Callie's going to speak to was a palliative care and advanced care planning in the acute setting. Thanks, Callie.
Sorry, I was on mute.
Happens to all of us, Callie. It's fine.
Sorry, I'm Kelly, and KDHS we're fortunate enough to be a successful recipient of the LMICS funding grant last year. We had a project called Early Access to Palliative Care and Advanced Care Planning in the Acute Setting. It was a great opportunity to improve the care of palliative patients in the acute ward. Next slide, please. KDHS provides palliative care and end-of-life care in the acute ward, which has a specific palliative care room. However, it's not palliative care funded. It's been identified both anecdotally and as a result of recent organisation-wide survey against national standards that there are opportunities for improvement in early access to palliative care and advanced care planning for inpatients at KDHS. The project was driven by studies that showed early palliative care intervention tends to improve quality of life, increase the chance of people dying in their preferred place of death due to better planning, and reduce the overall health system expenditure. Advanced care planning is a crucial element of quality palliative care, and then a good advanced care plan can improve physical, emotional, and social needs for both the individual well beyond their palliative care and into the bereavement phase for carers. Next slide. The Palliative Care Outcome Collaboration, or PEACOck is a national outcome and benchmarking program that intends to create a clinical language by embedding 5 validated clinical assessments into practice. The program aims to systemically measure and improve patient and family care outcomes in alignment with the national safety, quality and health standards and the national palliative care standards. Implementation of the PEACOck model has led to statistically and clinical significant improvements in patient and carer outcomes. PEACOck focuses on improving provision of palliative care with benchmarking focused on timeliness of care, responsiveness to urgent needs, pain and symptom management and family carer problems. PEACOck also has a strong focus on patient reporting assessments, hence supporting and strengthening the key principles of the Victorian Palliative Care and End of Life Framework. Next slide. The project at KDHS had 4 main objectives, and that was to review current processes for management of palliative patients against current best evidence and integrate that into our practice at KDHS, to benchmark KDHS pre-project, mid-project and post-project with our data against the PEACOck national targets, to build capacity of staff in the delivery of palliative care and advanced care planning by identifying skills needs and training needs and providing workforce education and training opportunities. And 4, to improve communication and transition between services in alignment with the standards and supported by optimal symptom management and advanced care planning. We chose PEACOck as our tool, and that we're continuing to embed that into the admissions process for all acute ward patients. PEACOck data is to be collected and entered into the PAL Centre app, so KDHS can be benchmarked against their national targets. And that will give us information on how well we're providing palliative care ongoing in our acute setting. Next slide. The challenges of this project initially started with feedback from our ward staff saying we do end-of-life care really well here. We have end-of-life care plans. Why do we need PEACOck assessments? And it was obvious from the start that they didn't understand that palliative care was more than just end-of-life and dying. Education really had to start with understanding that palliative care system, symptom and pain control, early intervention to improve quality of life, and to plan for end of life with advanced care planning and palliative care services involvement. COVID obviously played a big part as well, especially across the middle of this project. It made staff frustrated at more learning, more forms, more work for them in an already really busy time with increased staff shortages, general burnout, fatigue, code browns, and everything that came with that. We did offer education sessions in a variety of methods, online and face-to-face, and we put the PEACOck self-directed learning modules onto our online education hub for everybody to access. We enlisted the help of 2 ward champions that attended the trainer-trainer sessions, and they've continued to educate staff and will continue to educate staff moving forward. The ward champions were also unable to have dedicated days throughout that time period due to staffing shortages, but they did as much as they could whilst working their acute ward shifts. They completed audits, education, and helped facilitate the PAL Centre app installation and training for the ward clerks. They're super keen to see this project be successful and are planning, now that staffing has settled, to have dedicated days each roster over the next coming months to fully complete the final tasks and embed PEACOck into the acute ward setting. Next slide. So what's next? Our clinician survey that was initially conducted in July 2021, which showed this gap in staff education around end of life and dying, will be repeated. It also showed that while the staff believed that end-of-life care was done really well at KDHS, they lacked confidence in talking to patients and their families about death and dying. So we plan to repeat this survey to see if there's been any improvements with since the commencement of PEACOck and this project. The aim of the project was to increase the staff understanding that palliative care commences much earlier than at end of life, and that early interventions and access to external palliative care providers, good symptom and pain control, and advanced care planning and understanding that if you improve, by understanding this, you improve staff's ability to have those difficult conversations with confidence and much earlier with patients, carers and their families. At KDHS, we are aiming to continue to embed and implement PCOC assessment into the admission process so that patients are screened and commenced on PCOC early, referrals are attended early, and communication to external palliative care services is effective and timely. We'll continue to enter our assessment data into PalCentre to see how we compare with the national targets, and we'll re-audit the patients on PCOC to see if they've had an increase in advanced care planning and palliative care referrals. Thank you.
Thanks so much, Callie. That's fantastic. And if you could just stay on the screen, I do have a question, but I'm really keen if other people have got questions, if you could just pop those in the chat. So, Callie, I think you've done an awesome job. You know, you had obviously we all had COVID, but, you know, you were trying to run an acute setting whilst COVID was happening. I know you had staff changes as well. And yet you know, you've spoken of some fantastic outcomes from the project. I was particularly interested in you were saying about the way that staff's understanding of what palliative care is and could be had sort of changed, and that you had some staff education, knowing that most health services have a rotating workforce. Do you see that education being something that's built into your ongoing professional development program?
Yeah, I had a conversation with the education team just last week about embedding it into 2023. So we'll have it as a monthly in-service, and I will continue to ensure that any PCOC webinars that they have will be forwarded through to the education team. So we've got a plan to have it ongoing continuously, because we do have new staff, new grads starting all the time. So, and the education modules are available on the intranet at all times for them as well. So, yes,
that's great. Now I'm just going to check in whether there's any questions in the chat. Not at the moment. So we will proceed because we're trying to keep to time. So thanks so much, Callie, for putting the effort into capturing all that feedback, and we're delighted that the small grant was able to help you achieve those local changes. So the next presentation is actually a pre-recorded presentation, and that's from Sharon McGowan. Sharon's the Allied Health Team Leader within the Bendigo Cancer Centre, and their small grant was in relation to prehabilitation. So we hear a lot about rehab and post I'm stuck for words. But this is particularly around prehab, which is prior to people commencing their treatment. So we'll listen now to Sharon's presentation.
Hi, I'm Sharon McGowan, Allied Health Team Leader for the Cancer Centre. Firstly, I'd like to thank Olympics for the opportunity to present today, and secondly, to apologise for not being able to attend in person. I'll provide my contact details in the final slide if there are any queries which you may have in relation to this presentation. According to a study in the American Journal of Physical Medicine and Rehabilitation, prehabilitation is a process on the cancer continuum of care that occurs between the time of cancer diagnosis and the beginning of acute treatment, and includes physical and psychological assessments that establish a baseline functional level, identify impairments, and provide interventions that promote physical and psychological health to reduce the incidence and/or severity of future impairments. In addition, as per the Macmillan Prehabilitation Evidence and Insight Review, prehabilitation is not a standalone intervention and should be considered an integral part in the whole rehabilitation pathway. With the ongoing need to improve patient outcomes and to increase work efficiencies, options such as prehabilitation offer a relatively low-cost option to maximise function prior to surgery and to reduce morbidity associated with surgery. The use of prehabilitation within the cancer population is much more recent than in other settings, but is gradually becoming recognised for its potential benefits. In 2020, clinicians in the Cancer Centre, recognising the need within their patient populations, applied for a LMICS grant to assist with the establishment of such a program. One caveat is that we did not have access to psychology services at that time, but we do have availability of social work staff with issues such as adjustment disorder or if other issues are identified. Patients were also directed to other psychology options if that was needed. The objectives of the project were to develop, deliver and measure the prehabilitation project. In developing the prehabilitation program at Bendigo Health, the following tasks were completed. Benchmarking and liaising with other hospitals already running an oncology prehabilitation model. We did this by working with Peter McParkville to understand and gain good insight into their program. In developing a sustainable referral system, we utilised standard pathways with new processes to manage referrals from MDMs. So the focus of this was really on education for health clinicians. In determining an appropriate prehabilitation model suitable for patients accessing cancer services at Bendigo Health, including regional patients, we created and adapted a model, but this will be reviewed over time in tune with the needs of the consumer and service. Designing resources to promote and run the program resulted in the consumer booklet to monitor goals, and we also have patient and clinician promotional brochures. We developed processes and procedures for the program. Our second aim was to deliver the program, and thirdly, to measure the outcomes of the prehabilitation program, including the utilisation of objective baseline measures and to collect data relating to referral numbers, the source, the numbers of referrals onto community post program, and finally the provision of the project feedback. Delivery of prehab in our setting involved providing a group-based program, so it was always going to be a clinic-based program. The program was delivered by a physiotherapist, exercise physiologist and dietitian. Initial assessment involved completing the following objective assessments: the malnutrition screening tool, grip strength, quality of life measures, the 6-minute walk test and the 30-second sit to stand. Once assessment is complete, there is development of a program plans based upon the needs and goals of the patient. And this generally included the provision of individualised exercise-based programs, both in-centre and in home-based. There a provision of resources. To this end, we created a booklet in which patients can self-monitor their weight, can access their home exercise. It has nutritional advice and copies of baseline measures. At triage and after assessment, clinicians identified those patients suitable for the prehabilitation program, with those not suitable being provided with a more appropriate service either in-house or by an alternative provider. Referral to the dietitian is a component of the care which is initiated by the exercise physiologist or physiotherapist at initial assessment or as a result of the ongoing monitoring of weight. Following up care was dependent upon the needs of the patient. And then, of course, came COVID-19. As a result of the pandemic, some of the logistics for the program needed to be altered. Restrictions to people attending to the hospital meant limitations to running the groups face-to-face. So instead, a remote model was adapted whereby patients were assessed face-to-face as able and provided with a home-based program. And there was increased liaison with local service providers, which had been planned in any case. Finally, measurements. Over the 9-month course of the program and with COVID issues looming large, we had 35 referrals, with 32 completing the program in either the group or home-based care. Patients included in the program have been those undergoing neoadjuvant chemo and radiotherapy, including patients with colorectal, breast and lung disease, and those with a hematological cancer with plans to undergo stem cell transplant. Referrals have come from medical, nursing and allied health staff within the centre, including the multidisciplinary meetings, and there have been some from inpatient-based staff. Staffing for the program consists of 4 hours each of the physiotherapy, exercise physiology and dietetics, and as a result, the collation of data onto a central point was limited. We are currently in the process of completing the final report. There have been some unplanned outcomes. This included being an invitation to be involved in 2 other Peter Mac projects relating to rehabilitation. We've had increased opportunity to liaise with other clinicians to develop stronger links, specifically with surgical staff. And we've had a presence in the MDM meetings in the Cancer Centre. Although specific funding for the program is finished, the prehabilitation program has now been absorbed into usual care, and as a result has had to undergo yet another transformation. So instead of being a standalone program, patients are allocated to existing groups based upon their scheduled preference. Because our program is provided within the Cancer Centre, this is beneficial for patients by allowing them to limit attendance at the hospital. However, it does provide some logistical challenges for staff. We're actively looking at funding models to make this a sustainable model in the long term. Thank you so much for your time. Sorry for the quick delivery. Please feel free to contact me if you have any queries. And once again, I'd like to thank LIMICS for providing this initial funding to kickstart this program. Thank you so much.
Thanks to Sharon for providing that presentation. The 2 points that really stood out for me was reinforcing the multidisciplinary cancer care team. And we know that that happens so well across our region, and that's a real, it's something that we should be very proud of and be very appreciative of with all the clinicians that work so hard to make that happen. And also the mention of that small grant project now being absorbed into business as usual activity, which is also a really important part of a quality improvement process. So thank you to Sharon. So we're moving right ahead. We have gone from Kyabram to Bendigo, and now we're moving to Echuca, where our wonderful colleague Lynn Jefferson, who's the nurse unit manager in the Echuca. Yes, hi Lynn.
Hello.
Yes, lovely to see you. So I'll just explain a little or provide a brief introduction about the model of care. So model of care, as most of you would be aware, it's really around documenting the process that a patient receives their health care in, so that the patient gets the right care by the right person in the right place and at the right time. But, that sort of sounds quite like a cookie cutter sort of recipe. And we know that the world isn't like that. And so we funded Mildura, a conglomerate of health services in Mildura, Echuca Regional Health and Swan Hill Hospital, to really take the time to investigate what was their optimal model of care and what would have to be put in place to actually implement that model of care within their health setting. So we funded those projects in 2021. And then what happened later on in 2021 was the state government also provided a really exciting initiative to all regional cancer centres, which included the Bendigo Regional Cancer Centre, where they were commissioned to do a 5-year service plan that was going to provide direction for the services from the Regional Cancer Centre across those regional areas and intersecting with those sub-regional health services. So LIMICS worked very collaboratively with the Bendigo Cancer Centre in that service planning process, and also brought together the 3 health services that were doing that model of care. And for those health services, they were employing consultants to do that project. And so we brought together the consultants, the health services, the Regional Cancer Centre service planner and LIMICS on a regular basis, so that we could really maximise the synergy between all that planning work that was occurring. So what we're going to hear today is from Lynn at Echuca. So Lynn, do you want to tell us about, your project? Now we've got all of about 7 minutes left, but where that idea came from and, the why in your mind. Why was it important to you to approach LIMICS around some of this project funding?
Thanks, Cheryl. Yeah, I'll just dive straight in. So it was really important for this health service to look at how people with a cancer diagnosis and other chronic illnesses that we also look after access services, and what we should be providing for people, particularly as this area population grows. We know that there's older people living in our areas, and so it was really important that we were looking at the future ahead. The real impetus, I guess, from there was for us to actually think about our new Cancer and Wellness Centre and how that would function and support our people to access care, but also looking at the care across the continuum. So not just centred around treatment, but more broadly from diagnosis and in beyond treatment to survivorship or other care needs as people went through. So that was really the impetus for us to look at developing a model of care.
And I'm interested, Lynn, to hear how you engage strong consumer input into this project. So if you'd like to just give...
Yeah, I guess we're very lucky. I think generally we have good engagement with our community in Echuca and from Echuca Regional Health, and also working within the service, being able to speak directly with people coming in for treatment and their carers, and having the close links with community in that way, but also utilising social media, traditional media as well, having close links with patients and carers. We're able to ask for their consent to reach out to them and, send invitations and make that personal approach to engage people into the project. And, we've been very lucky in that way that people have been interested to tell their story and be provided with that opportunity to do so.
Yeah, no, that's great to hear. So I know you've had a consultant working with you on this project over the year. You've done lots of consultation, focus groups, interviews, looking at the data that informs, projected service usage as well as current service usage. I think your wonderful wellness centre is opened or opening.
Very close to opening.
Very close. So there's a lot of exciting culmination of this work. How would you sum up some of the key outcomes of the project? And is there any particular area of the project that you'd like to focus on as an outcome that gives you pride?
Yeah, I think we're really excited about the outcome, because it is quite comprehensive, and it is based on key areas, policy direction, what's happening in our region, what our patient demographic, all that's looking like. And it's very prospective, thinking towards models that are more integrated, that support people in a more holistic way. It's also details the workforce development required going forward. How are we going to look after people going forward? How are we going to meet the needs, and what does our workforce look like? And also for us to be able to, there's an evaluation aspect of the project as well. So it's really enabling us to look forward to the next 5 years. So the project is over the next 5 years, and to implement the model of care. And then how do we evaluate it? That's all stepped out for us, which is really important, as you said earlier, in regards to quality. Have we achieved what we set out to achieve? And be able to measure our success. Certainly, I think the consumer engagement and just the engagement overall with all key stakeholders has been a real success. You know, engaging Alison Coughlin as our consultant was fantastic in that she was able to make sure that we were engaging really well with other key stakeholders, including other regionals, as you mentioned as well, in the broader picture, and matching, I guess, with some aspects of other models of care, and making sure there was good collaboration there. So that was great. I think, making sure that we were true to our first brief around the centre, that it should be welcoming to all, and engaging with people like that, acknowledging cultural aspects, but just that welcoming to all, and what does that look like for people. So starting with what mattered to most for people with a lived experience of cancer, and really that was central to everything else that has come through in the model of care. And
so it's great that you're really describing something that's been very responsive as well as very agile moving forward. I'm interested to know, did you have any unexpected in terms of managing a project like this? Was there anything unexpected or anything that you had to adapt to, apart from obviously the pandemic?
Yes, that's been a bit of a challenge. I think certainly, we were lucky enough to have an additional resources to extend the scope of the project, to include workforce development and evaluation, and I guess more of outlining the services going forward. So what would workforce look like to deliver those services going forward? So we had to adapt around the change in scope there, which we were very grateful for. And I think that's made it a far more comprehensive project, or the outcomes are much, much closer aligned with what we hoped for.
Great. Lynn, I am getting the wind up. So I'm just wondering, are there any questions in the chat, Simon, and while you're identifying that, would there be any quick take-home messages if there's other rural health services looking at possible model of care projects, Lynn?
Absolutely. You must gain support from executive, and you need to understand competing interests and utilise efficiencies where possible. Clear idea of the goals and timeframes, be prepared to be flexible, and gaining expert project support was absolutely key. And yeah, again, acknowledgements to LMICS and Alison Coughlin for this project.
Thanks, Lynn. It's a challenge to get across so many salient points in a short period of time, and you've done exceedingly well. Any questions, Simon, that I need to pay attention to? No. So I'm just going to have a little changing of the guard now with my colleague, Vanessa, who's going to interview our last presentation, which is from Susan Bibby. So Susan is a nurse at Swan Hill District Health, and she's going to speak to the Aboriginal cancer care and the implementation of the optimal care pathways. Sorry, I said Susan. I am so sorry. It's Leanne. I do know a Susan. I'm so sorry, Leanne.
That's fine.
Completely fine. It's been a very big week. Just to pop everything in context, we've also been pulling together our annual report, haven't we, Cheryl? So, okay. Great to be with you, Leanne. I've spoken to you about your project on a couple of occasions now, and I can't wait to dive into a few questions. So your project, Enhanced Understanding of Aboriginal Cancer Care and Implementation of the Optimal Cancer Care Pathway for Aboriginal people. Can you tell me a little bit about the project and where the idea came from?
At Swan Hill District Health, we identified a few gaps in our referral processes, to namely McGrath Breast Care Nursing Service, our cancer care coordination, in community health, allied health sort of fields. And so we really wanted to look at how we could strengthen connections, and also work with MDAS, our local Aboriginal Health Service, as a side-by-side collaboration to look at how we can better support our Aboriginal people with their cancer support services. So within the cancer care pathway and also within the cancer care plan. But that's basically the crux of where we started from with this project.
Such a great starting point and such a great why. And I know there's some fantastic detail. And I loved how you touched on strengthening connection, because this is fundamentally what the project is all about. Can you sort of walk through the process that you took and the key outcomes of the project, and particularly the things that you're really proud of?
The process changed a few times over the time period. I'd come up with an idea, and then we'd look at a strategy, or we'd go back to our advisory group, and COVID threw a spanner in the works on how we went about the project. So it did change. We were lucky enough that we had the development of an Aboriginal health unit within our health service. So we really looked at how can we embrace that unit and the staffing within it, and we started a collaboration with them. So from that, you know, one of our major outcomes we're really proud of was the development of a resource card, and now to work in with how we can get a referral from our Aboriginal health workers, say at MDAS, Swan Hill or Kerang, into our mainstream services, so we can really help support. So we did an education service with them, with the Aboriginal health workers and their health department at MDAS, and really looked at what can we do, how can we help you. So I actually picked up today, and we'll send them out. So we've established a reference card that on the outset transition our referrals through our Aboriginal health unit. So thinking outside the square, but really looking at what our evidence showed us about cultural awareness, cultural safety and respect. And so we've identified a direct link from referral places to our Aboriginal health unit as a direction for them to then have an interview with the consumer and look at the cultural aspects and be really aware of what their needs might be before referring to a service like the McGrath Breast Care Service, our Cancer Care Coordination, Allied Health Dietitian, for want of a few different caregivers. So we've really thrown that process and teased it out and looked at the benefits, and we really hope that that'll just provide another avenue to collaborate our care from our MDASs to mainstream services, with the view that it's not taking over, it's working in collaboration and really supporting what they're doing.
Yeah, I absolutely love that model, Leanne, and particularly around sort of the development and strengthening of capacity of workers at MDAS and the provision of the resource card to sort of, you know, build those relationships and trust and feed referrals into your service, and also services connected. And I know that you did some other work as well around sort of developing relationships in the community over the year. Can you sort of tell me a bit about a couple of initiatives that you participated in or that you knew of?
Yep, I spent some time trying to reach out to some organisations. So the one thing with COVID, the health professional aspect out of MDAS was really focused on chronic disease management. So linking back in with their health promotion workers and trying to, you know, get that going again. I attended a health promotion day after they'd attended their breast screen. So Tony Webster and Kerang MDAS had done some wonderful work in ensuring the Shaw project, the beautiful Shaw project, in conjunction with breast screen. So I was able to go to a Pamper Day following all their screening and really look at connecting with key stakeholders, connecting with the community, asking about their needs and what is it that you want in relation to accessing screening services and the promotion, getting back into that promotion of screening, risk factors and access to services in the screening centre and prevention. So, and that was really vital and key to then progressing with some of the things that we were able to work out towards the end of the project.
Yep. That's all right, I don't want to cut you off.
NAIDOC Week was really crucial because with health promotion at Swan Hill District Health, we ran a stall up there with Swan Hill's NAIDOC Week celebrations, which was awesome, and met public and also met key workers in a whole lot of different areas that access and work with Aboriginal people, and not only in the cancer space, but that turned out to make some great liaisons that then got me involved with MDAS in the health specific unit, and then set up the education session.
Fantastic. It just sounds like such a fantastic and such a rewarding project, particularly post-COVID as well, and being able to get back out in the community and build these relationships to make changes. We're coming to the end of our mini conversation, but I'd be interested to sort of understand, if there are any sort of rural health services that are wanting to undertake work. What are some key learnings that you could possibly share with them?
The big one for me was not having to reinvent the wheel. There's some absolutely great resources out there, and I conducted a literature review and looked at some really key workings at a lot of our First Nation people, and really valuable outcomes that could show us what do we need to do as a mainstream health service to really try and embed some and make some structures really culturally aware, culturally safe, and really promote self-determination, and they were the key outcomes that I got out from every bit of literature that I read. And so for me, if I was doing another project, it would be finding out all that information and evidence, and really what will make us move forward in and strengthen our relationships between our Aboriginal consumers and mainstream health services.
And just finally, Leanne, what are you looking forward to next? I know there's one final piece of work or training that you might be undertaking.
Yes, we're really excited to, and you might know the exact termination, the wording than myself, but the Optimal Care Aboriginal Learning Program. We're really looking forward to participating in that in a train-to-trainer type arrangement. So we will embed that into our trainings for next year, and absorb that into whatever we're doing now, and look at the best people to undergo that. And that will really move forward the learnings that we take home, and also in conjunction with our Aboriginal Health Unit, that is just going to go from strength to strength and really expand their services, and also MDAS health workers, and really take it to the next level, what we've started with this project.
Sounds fantastic. In the end, it's all about sustainable change. So thank you very much, Leanne Bibby. It was wonderful speaking with you, and I will hand back to Cheryl now.
Thank you very much.
Thanks, Leanne. It was great to hear that, having been involved at some of the project development stage. And I think that's what's been really fantastic for us as the LIMICS team, hearing the culmination, because these projects, they don't just drop from the sky. There's obviously a lot of work that the people developing the projects, our team supporting the projects. So it's really exciting, and I hope as participants today you've enjoyed just hearing firsthand how working together with you as stakeholders and with everybody in the cancer sector can really bring great results. We have had a couple of little technical challenges with the chat and the questions, so I apologise that hasn't been open for the full time, but we are running out of time. If anybody has questions, please feel free to reach out to us through LIMICS, through any of us, or through any of the presenters today. And just finally, we've really enjoyed, maybe I'm telling fibs if I say enjoyness, we've been working hard on our annual report. What we've enjoyed is actually capturing the diversity of the work that's occurred during the last year. And we've put that together in what we hope will be a really readable annual report, not just for the Department of Health, who are not only our funder, but a group of professionals that are really committed to the implementation of the cancer plan, and who do resource and support us as an integrated cancer service. So that report will be lodged with the department, but we will distribute the report to all of you as participants today, and to a broader range of stakeholders across the Loddon Valley region. So in conclusion, I would like to thank the LIMICS team for supporting me today to put the annual forum together. And mostly I would love to thank the participants who shared their really realistic feedback on the small grants and the model of care projects. And to you as people that have put aside the time to participate in our forum today, thank you so much. And good afternoon to everybody.